Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sarjan, your MC for the session. If you wish to claim your certificate for the same, kindly visit your website, which is www.onlinedentistry.in/9pm and register for the same. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. Our motto is to redefine dental education. It's been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 203 official courses and we have conducted 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Viruti Abraham, who is one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Alva. Currently, he's interested in educating thousands of clinical practitioners through both online and offline sessions. Moving on to our academic head of online dentistry, Professor Dr. Joby Peter. Currently, he's the HOD of Department of Pediatric Dentistry at Anu Dental College, who preaches a philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. The latest addition to our courses, the one-year comprehensive and advanced master training program on interceptive and myofunctional orthodontics, have been successfully initiated with 2 batches. This is a multidisciplinary approach with in-depth training and hands-on sessions. Our program is now a fellowship program on interceptive and myofunctional orthodontics, which is accredited by the Manipal University College, Malaysia, which is also a sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with the graduation ceremony and a certificate distribution as well. So we are open for registrations for the next batch, which commences on September 22nd, 23rd, and 24th via our website. So right now, we are left with only 2 seats. Register yourself so as soon as possible. On popular request, we are coming up with yet another interesting workshop on interceptive and myofunctional orthodontics, which has been held on the 23rd, 24th, and 25th of June at Kochi. We are left with our last seat, so grab it at the earliest. You can always feel free to reach us on our WhatsApp numbers and visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for the 14-year past duration. So during lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same by providing advanced learning series under the title Online Dentistry at 9 p.m. So, without further ado, let me move on to introducing the speaker for the day, Professor Dr. Sivadas Ganapathy. He secured his BDS from Sri Mookambika Institute of Dental Science, Tamil Nadu, and his MDS from Manipal College of Dental Science, Manipal University, Mangalore. He is currently the Faculty of Dentistry at Asian Institute of Medical Science, Technology, MX University, Malaysia. Previously, he worked at Sri Mookambika Institute of Dental Science, Tamil Nadu. He's also a fellow of Academy of Dental Education, Manipal University, and also a fellow of International College of Dentists. He has secured a universal certification in forensic odontology from the International Forensic Science. Furthermore, secured a diploma of membership of the Faculty of Dental Surgery of the Royal College of Surgeons of Edinburgh. According to numerous publications, his field of research interest is pulp revascularization and rotary endodontics. He's also the consultant periodontics in numerous dental clinics. Moving on to his accolades, he is a recipient of the Best Paper Award at the 40th Karnataka State IDEA Conference held at Mangalore, and also the Best Paper awardee at the conference on case reports in pediatric dentistry. Proudly welcoming the star of our session. Sir, the session is all yours now.
Thank you, Dr. Anita, for that wonderful introduction. Just allow me to share my screen.
So,
okay, very good evening to one and all. Greetings from Ames University. This is our campus where I've been working for the past 8 years. And we have got one of the best campuses in Malaysia. And I welcome you all to our university someday. And before I begin my presentation, I would like to express my sincere gratitude towards Dr. Joby Peter, who has given me this opportunity to share my views on management of non-vital young permanent teeth. Now, this topic is of interest to me. Why? Because initially when I started my practice, I always had this dilemma regarding this management of non-vital young permanent teeth, when to go for apexification, when to go for revascularization. So I thought I'll present my presentation on this topic particularly. And today in this topic, I will be sharing few cases that I have managed. And at the end of this session, if you can decide when to go for apexification, when to choose revascularization, the objective of my session will be achieved. And I've been told that this is a mixed audience. So I will start with few basics and slowly I'll go to the topic per se. Okay. And to start with my presentation, we all know that young permanent teeth is one that has been recently erupted. And the physiologic root closure has not been completed. Usually for this physiologic root closure to complete, it will take approximately around 2 to 3 years. Now, any injury during this eruption stage, either due to deep caries or traumatic injury or any tooth malformation, will invariably affect the root apex closure. Also, it can be due to either due to extensive orthodontic forces or any periapical pathology, or even over-instrumentation sometimes can cause open apex. Now, routinely in our practice, we get traumatic injuries with the complicated crown root fractures that can cause open apexes. Now, it is not only these kind of complicated crown root fractures. Studies have shown that even untreated dentinal fractures over a period of time can cause pulp necrosis, which may affect the root development. Not only we take a history based on the age, when the injury has occurred, where the injury has occurred, and we try to arrive at a diagnosis. Before we arrive at a diagnosis, we go for the pulp testing. Now, routinely we go for pulp sensibility test, like either electric pulp testing. Even though this pulp testing is not as accurate, especially in young permanent teeth or recently traumatized tooth, but still we do that just to establish a good baseline data. After that, we go for investigations. Now, once we complete the investigation, then we go for the diagnosis. And the diagnostic terminology, we generally follow the AAE, the American Association of Endodontic terminology we follow. And once we do our diagnosis based on our investigation, we arrive at either the diagnosis of either irreversible pulpitis or it can be a necrotic pulp. Now, the management of either irreversible pulp status or the necrotic pulp is only two, very limited management. Now, the AAE case difficulty has also suggested that when the apex is open more than 1.5 mm, or whether the injury has been caused due to complicated crown root fracture, especially on the young permanent teeth, the case difficulty is extremely high. And as I mentioned, the management of non-vital young permanent teeth, the treatment options are only two. It can be either apexification or it can be revascularization. Now, the general treatment options for non-vital young permanent teeth are the previous techniques that were followed. We are using the customized roll cone technique, the short fill apex technique. Then we have got apexification, single visit apexification, and regenerative endodontic procedures. The first two mentioned procedures are totally outdated and is no longer done. More recently, follow apexification and regenerative endodontic procedures. Apexification is basically we try to form a root barrier because the root length has not been taken place due to damage to the Hertwig's epithelial root sheath. So we want to close the root apex. That is the basic idea of doing apexification. Now, historically and generally, most commonly, the technique that is being followed is the calcium hydroxide apexification. Now, calcium hydroxide apexification has got a lot of advantages. It is very easy to do, convenient. Basically, we do the access opening and we place calcium hydroxide and we wait for the barrier to be closed. Now, the timing of change of calcium hydroxide, different authors have suggested different time period. Now, to summarize this, it basically depends upon two factors: how much amount of apical closure we want, and with what vehicle we are going to mix calcium hydroxide. Now, if the apex opening is quite wide and large, then it is obvious that we have to wait for a longer period of time. And the frequency that we change the calcium hydroxide dressing depends upon the vehicle that we are going to mix calcium hydroxide with. Now, if we use a thinner vehicle like saline solution or distilled water or even chlorhexidine, the release of the free calcium ions are faster there. So we have to change the dressing very frequently. But suppose if you are going to go for a thicker mixer like a vehicle like a propylene glycol, there we need to change less frequently. But the calcium hydroxide apexification, here if you see, the barrier has been formed within 1 year. Now, there are quite few disadvantages of this calcium hydroxide apexification. If you compare these two roots, the 1-1 and 2-1, the root lengthening has not been taken place. The root length remains the same. So if you see, the total root length is even shorter than that of the adjacent lateral incisor. So the overall crown root ratio is compromised when we do calcium hydroxide apexification. And not only that, the time period that which we require is extensive. It may take 6 months, sometimes 1 year, sometimes even more. And even though we wait for a longer period of time, the barrier that sometimes being formed is not very hard. They say it is like something like a Swiss cheese in consistency. So what happens is when we are going to obturate the tooth eventually, sometimes when we apply some kind of apical pressure doing apical condensation, what happens is the barrier tends to break and the sealer tends to extrude. Sometimes even GP has extruded because of the immature barrier is being formed. Now, they say calcium hydroxide apexification can cause root fracture, but generally it has been proved that it is not due to the calcium hydroxide that the root fractures, but it is because of the thin and fragile roots the root fracture takes place. So calcium hydroxide as such doesn't have any role in root fracture. So these are the various disadvantages of calcium hydroxide. So a search for a newer material was there, and of late, more recently, I would say a newer material was introduced. And this was introduced in the Loma Linda University by Muhammad Torabi-Najat. That is the mineral trioxide aggregate. Now, ever since the introduction of this material, the treatment of young permanent teeth, as well as in pediatric dentistry, in restorative dentistry, it has been revolutionized because it has got a variety of uses and the biocompatibility of this material is excellent. Now, the composition of the recently introduced biomaterial is the MTA as well as the biodentine. The composition is both almost similar except for a few additives. Now, these two materials are similar in terms of the white Portland cement that we commonly use, except for the biocompatibility. Now, usually when we mix the MTA, we make sure that all the powder particles are uniformly mixed. Usually we go for 3:1 mixture. Depends upon the manufacturer also. Sometimes nowadays the MTA, some manufacturers, they prefer giving gel instead of the liquid. So it depends upon which company MTA we are using. And as far as placement of MTA is concerned, we have got a lot of carriers like MTA carrier, Rocan carriers, different system, MAP system. And even for routine clinical use, we can even try the common amalgam condenser that can be used for amalgam carrier. Sorry, the amalgam carrier can be used for placement of MTA. In this video, I'll show you how to place the MTA. Now, if you see generally, the MTA placement, we have to divide into 3 halves. Now, these are the basic minimal armamentarium that are used for placement of MTA. So if you place the MTA, we divide into 3 equal halves, the root surface. We have used the end-of-flow MTA for placement here. Now, the advantage of using end-of-flow MTA is that the gel we use here is much viscous, and the mixing will be, consistency of the MTA will be good. Now, once we do the access opening and we do the cleaning and shaping till the working length. Now, once we do that, we divide the root surface into 3 equal halves, the coronal portion, the middle third, and the apical third. So we take around 3 to 4 mm of MTA and we load into the amalgam carrier and we place into the orifice. Now, once we place into the orifice, we slowly have to push from the orifice to the cervical portion, inside the cervical portion. Now, that can be done using a commercial amalgam condenser. A smaller instrument can be used to push from the orifice to the cervical third. Now, from the cervical third, once we push completely, we have to slowly push to the middle third. Now, for pushing to the middle third, we generally can use the pluggers for the help. Now, whenever we are pushing the MTA, one important thing that we have to notice is make sure that your MTA doesn't stick onto the canal walls. That is one major problem when we push the MTA. So always when we push, make sure that the MTA doesn't stick to the canal walls. So now here, from the cervical third, we try to push towards the middle third with the help of a plugger or a spreader. Once we do that, we take a file and usually roll it into roll with a wet cotton and try to push towards the apical area. Now here, what we generally do is we have taken 3 to 4 mm of MTA. So we reduce the working length accordingly so that we won't over push the MTA. Now, newer studies, they say that we can place apical barriers, resorbable barrier materials in the apical area so that we will prevent exclusion. If barriers are not available, we have to be very careful when we are pushing. And when we are pushing, we tend to push in a circumferential filing. Now, when we do root canal instrumentation, we do something called a circumferential filing. Oh, same technique can be followed when we are placing MTA. We push through all the canal walls. When we do this circumferential pushing inside the walls, the MTA doesn't stick to the canal walls. Uniformly, it will be placed in the apical region. And when we use the wet cotton, whatever remnants are there, it will be wiped out from the canal walls. Now, this is a routine case where the 9-year-old patient presented with a class 3 fracture, complicated fracture, and the apex was open, and routinely around 3 to 4 mm of MTA was placed in this case, and the tooth was later obturated, and the crown was given for the patient. This was another case again. A patient reported with a complicated crown root fracture here, and since the root fracture was extending subgingivally, we had to do a 180-degree rotation so that the subgingival fracture on the palatal area became supragingival when we rotated. In addition, the tooth 1-1 was incompletely obturated and the GP was extruding beyond the apex, and the apex on tooth 2-1 was open. So we decided to go for retreatment as well as MTA placement. Now, in both the cases, we decided to go for MTA placement slightly beyond the recommended 3 to 4. Here we kept around 6 mm of MTA. Later on, the fiber post was given and a crown was given. This is again another case. Here there was open apex, the periapical lesion was present. This was due to carious lesion rather than a traumatic injury. And again, routine case where MTA was placed. Now, there are a few problems when we place MTA. like I mentioned, if you don't place a barrier and if your working length estimation is not proper, the MTA can extrude into the periapical area. Second thing is the MTA can be insufficient when we place sometimes. Now, this insufficient barrier can be due to improper powder liquid ratio. So the powder liquid ratio has to be correct so that consistency will be accurate. Now, again, if MTA is not correctly pushed up to the working length, required working length, it can be even short also. And as I mentioned, if we don't push through the canal walls, the MTA can stick to the canal walls also. And this is another example of irregular MTA placement. Now, generally, they say we learn from our mistakes, but I like to put it in a different way. You need not always learn from your own mistakes. You can learn from others' mistakes so that you avoid these kind of errors. But fortunately, when I learned initially, I made all these errors. But now, over the period of time, I have improved and I try to avoid these kind of errors. Now, as far as MTA and biodentin is concerned, the main problem with MTA is that it takes long time for the initial set to take place. It takes around 1 hour, and even the final set sometimes goes for 3 hours. But the advantage of using biodentin is that the initial and the final set is completed within 10 to 15 minutes. But for using biodentin, we have to be more accurate and the timing has to be perfect. If the material is not reached the apex, we don't have sufficient time to push the biodentin. That is the main disadvantage of using biodentin when compared to MTA. But once you are good with your technique, you can definitely go for biodentin instead of MTA because it sets much faster. As far as pushing MTA is concerned, you need not be worried because MTA is an excellent biocompatible material and it has got very low cytotoxic potential. And sometimes, even though it is extruded beyond the apex, very rarely it causes any periapical reaction. And over a period of time, when we observe, bone has been completely formed in that particular area. But always, as this, we say, any foreign material can cause some problem in periapical region. So we tend to not to overpush the material. Now, you ask whether MTA can be used for long-term apexification. The long-term studies have shown that definitely MTA is a very, very excellent, good material, excellent material with biocompatibility, and it can be definitely used for apexification procedures. Now, the drawbacks of MTA as well as biodentin, MTA takes long time, as I mentioned. And biodentin, the major disadvantage is that the working time is very short, and also it has got poor radio opacity. Now, the major disadvantage that is commonly seen in the MTA is that it can cause discoloration, especially in the cervical region when we do pulpotomies. So the major cause of the discoloration was due to the presence of bismuth oxide. Now, even white MTA causes discoloration. That has been the routine case. But if we apply a bonding agent before we go for apexification or placement in the coronal region, it tends to minimize the amount of discoloration. Another drawback of MTA, it is quite difficult to place in curved canals. What happens is when you place in curved canals, we require much finer instruments to push the MTA. So the MTA thickness that reaches the final apex will be very thin. And the remaining MTA that we place tend to stick onto the canal walls. So that is one major difficulty in using MTA in curved canals. And also, it is quite expensive compared to the calcium hydroxide. And even if unknowingly material sticks onto the canal wall or goes beyond the apex, you don't have any solvent that dissolves MTA. And also another major problem with MTA is that when we place 3 to 4 mm of MTA and then we obturate the root canal with Ganapathy, what happens is when we go for post placement, when we prepare the post space, when we tend to use a reamer, what happens is the MTA, because the GP doesn't have any apical tack, the GP when we remove, it comes out as a whole. Because nowadays we tend to use pro taper GPs rather than the commercial GPs, the initial GPs with the accessory combs. So in such cases, the GP can come out as a whole. So in such cases, one option would be you can go for around 5 to 6 mm of MTA placement and directly post placement instead of going for GP obturation and then removing the GP. So that is why in the previous case that I showed where I rotated the tooth 180 degrees, in that case, the specific reason for placing MTA 5 to 6 mm thickness was directly we could go for fiber post instead of GP. The disadvantage is that we will be utilizing more material, but it is much easier and convenient when we directly go for MTA plus post placement. Now, one major disadvantage that we see with either MTA apexification, biodentin apexification, or calcium hydroxide apexification is that there is no root lengthening, or the crown root ratio remains normal. So that has been a major problem with the apexification techniques. Only a barrier will be found in the periapical region. So there came a search for another procedure wherein we can the root grows in. So they found out a technique, newer technique, which is called as a regenerative endodontic procedure. Now, I wouldn't say this is a newer technique because as early as 1960s, attempts have been made on experimental models by Nygaard and Osby. And later on, recently, it was popularized by Banks and Ayawa in 2000, late 2000. Now, this regenerative endodontic procedure, one advantage is that it is based on the concept of tissue engineering, where the pulp dentin complex regenerates into a canal, and the pulp regrows also in the space of a non-vital young permanent teeth. That is the main advantage of doing revascularization. Now, there are a lot of terms that has been used. Initially, it was called as revascularization. Then it was termed revitalization. Then it was called as regenerative endodontic procedures. Now, all these terms are interchangeably used. Now, if you go in detail to know what procedure is happening, they say it is more kind of repair rather than regeneration. Now, regeneration is a process where the tissues that are native to that particular site regrows. But here, if you see in regenerative endodontic procedures, it is not only the root dentin or the cementum or the pulp tissue regrows. It is a combination of all the tissues that is formed in the periapical area. So it is better to say this is a process of repair rather than regeneration. Now, the main goals of this revascularization procedure, first and foremost, is we have to eliminate all the clinical signs and symptoms, and also there should be demonstration of good bone healing. Second should be, as I mentioned, the disadvantage of MTA. It should demonstrate increased root canal thickening. And last is an additional bonus. If a non-vital teeth responds back to pulp testing, it is an advantage of it. Now, for regenerative endodontic procedure to take place, first and foremost is we have to disinfect the root canal system. Now, disinfection of the root canal system is taken care by triple antibiotic paste and the irrigants that we are using. Second is we require a scaffold wherein it can hold the growth factors. Commonly, we use a scaffold that is the blood clot. And finally, we require an adequate coronal seal to prevent reinfection. Now, commonly used material is either MTA or biodentin. Now, as far as scaffolds are concerned, they have tried using different scaffolds which hold in the growth factors like dentin, blood clot. They have tried a collagen, peptide. This scaffold basically it supports the cell organization, proliferation, differentiation, and the vascularization. A very commonly used scaffold is either blood clot or the platelet-rich plasma or the fibrin. The whole process of regenerative endodontic procedure is mainly possible because of the stem cells that is present in a young permanent teeth. There are abundant stem cell in a young permanent teeth because of its rich blood supply. We got your periodontal ligament stem cells, dental pulp stem cells. Even in a non-vital teeth, we have dental pulp stem cells. Then we have got dental follicular stem cells, apical papilla stem cells. All these stem cells help in the regrowing of the root complex here. Now, the most important thing is we require growth factors. Now, the growth factors mainly we have got the bone morphogenic protein, then we have got the fibroblastic growth factor and the transforming growth factor beta. Now, as far as the bone morphogenic protein and the fibroblastic growth factors are concerned, they mainly take care of the bone formation, the root development, while the TGF, transforming growth factor, they take care of the angiogenesis. Now, there are a few considerations that we have to see before we go for the regenerative endodontic procedure. First and foremost is the patient selection. Now, this procedure is ideal when we do in a young patient. They say maximum 12 to 18. That age group is the most ideal, 8 to 18 years age group, where the apex is open, where the blood supply is abundant, and patient does not have any medical compromise or any medical issue should not be there. And the pulp should be necrotic and immature. And there should be minimal or no instrumentation of the dentinal walls. Why? Because already the dentinal walls are thin and weak. So preferably there should not be any instrumentation. And also it should receive an ideal intracanal medicament to disinfect the canal. And also there should be presence of blood clot or a protein scaffold, and there should be an effective coronal seam. So these are the basic requirements before we go for the regenerative endodontic procedures. Briefly, I'll tell you how to do this regenerative endodontic procedures. We always start with local anesthesia and rubber dam isolation, and then we start with the access opening. Once we do the access opening, we don't do any instrumentation. We directly go for sodium hypochlorite irrigation. And they say basically sodium irrigation 1.5%, at least for 5 minutes we irrigate with minimal pressure. Make sure that the sodium hypochlorite does not extrude into the periapical region. Sometimes what happens is when the sodium hypochlorite extrudes beyond the apex, it can damage the apical papilla stem cells. So there should be minimal pressure. And once we do irrigate with sodium hypochlorite, it is flushed with saline. Once we do that, we slowly dry, and then we go for the triple antibiotic paste. Now, as I mentioned, the triple antibiotic paste commonly we use ciprofloxacin, metronidazole, and minocycline. Now, the triple antibiotic paste takes care of the disinfection of the root canal along with the irrigants. Now, the main advantage of using this triple antibiotic paste is that this got a antibacterial polymicrobial infection coverage will be there. This Cipro usually covers the gram-negative spectrum. Mino is a broad spectrum antibiotic, and metronidazole usually takes care of the anaerobic bacteria. Now, the major disadvantage of using minocycline is sometimes it causes yellowish discoloration of the tooth. So before we place, we can seal the chamber with a dentin bonding agent, and then we place the triple antibiotic paste into the canal, and then we seal with a temporary material. Now we wait for around 2 to 4 weeks in general for the triple antibiotic paste to act. Now, how do we assess the response to initial treatment? There will be a resolution of pain, there will be a resolution of any sinus tract or abscess present, and the tooth would have reduced its mobility. For the second appointment, we generally again start with anesthesia, but here we tend to go for anesthesia without a vasoconstrictor. The reason I will explain. Now, once we start with anesthesia, then we place a rubber dam and we irrigate here with EDTA here. First, we remove the material with the saline and then we irrigate with EDTA. The main advantage of using EDTA is that it opens up the dentinal tubules, and when the dentinal tubules are opened up, it releases a lot of growth factor, and that is a major advantage and removes the smear layer. Once we irrigate with EDTA, we dry with paper points, and next is the most important step. We take a file, 25 or 30 size file, and we instrument beyond the apex. to introduce bleeding into the root canal. Now, for bleeding to be sufficient to fill the root canal, it is recommended to use anesthesia without vasoconstrictor. And usually we stop the bleeding around 3 to 4 mm by placing a restorative material. Now here, usually we go for MTA or biodentine. Now this MTA or biodentine should directly be in contact with the clot. Some others, they recommend placement of a material or resorbable matrix and then placement, or it can be placed directly also. And over that, we place directly glass ionomer cement. Now, this is the whole procedure, pictorial representation of revascularization. Access opening, working leg determination, minimal instrumentation, irrigation, and then triple antibiotic placement. Second appointment, removal, EDTA irrigation, introduction of bleeding, placement of MTA, and permanent restoration. Some authors, especially the European Society, they even recommend the placement of calcium hydroxide instead of MTA. But this is a bit controversial. I'm not going to the details because some authors, they recommend that the alkalinity of the calcium hydroxide can damage the apical papilla stem cells. But mostly all the authors, they prefer going with MTA or biodentine. Now, as far as triple antibiotic based combinations are concerned, the triple antibiotic paste always enables to reduce the number of colony forming units in the root canal system. Now, traditionally, the metronidazole, ciprofloxacin, and minocycline has been used. Minocycline always causes this yellow discoloration. So instead of that, they have tried metro, cipro, and cefaclo, and they have also tried doxycycline. Different combinations have been tried. Even double antibiotic pastes have been tried. Most of the authors, they prefer going for metro, cipro, and minocycline combination. As far as the discoloration potential is concerned, it can be covered by using a bonding agent. Now, follow-up generally we do clinically as well as radiographically. How do we assess the successful nature of a procedure? Clinically, there should not be any pain. There should not be any soft tissue swelling or a sinus tract. And in addition, if the tooth responds to pulp vitality, but that is only in addition. Radiographically, there should be a resolution of apical radiolucency. The root canal wall should increase its length as well as its thickening should take place. These are the major success criteria how we assess a procedure of revascularization. As far as scaffold is concerned, most commonly we use either a blood clot, a plasma, or a fibrin. Now, when we compare these three, studies have shown that maximum root closure takes place with platelet-rich fibrin of all the three methods. Now, if you see the types of closure after revascularization, not always that the tooth becomes normal elongated. There can be different types of fate of the apex closure. Now, type 1 is the most ideal, where the root lengthening has completely taken place, the root thickening has taken place, and the apex has closed completely. Type 2, I would say, is less ideal because the root lengthening has taken place, but the apex remains blunt and it is not fully closed sometimes. Type 3, the root closure continues to take place. Here we tend to wait for a longer period of time. Now, type 4 is one where we commonly see sometimes with obliteration of the root canal space, and we exactly don't know what forms inside, but completely the root canal will be sealed. And the last one is a hard tissue barrier will be formed in between the MTA as well as the apex. Again, this hard tissue barrier sometimes is irregular when compared to the stage 4. Now, why these different types of closure takes place? If you remember, initially I mentioned that even though the term used is regeneration, regenerative endodontic procedure, this is not a process of regeneration. This is more kind of a repair, because in regeneration, ideally, your tooth dentine, your cementum, your pulp, your periodontal ligament cells should have been formed. But it is not like that. Sometimes even bone deposition takes place inside the root canal. Now, why this difference? Why this is a process of repair? Now, why? Because the presence of the lipopolysaccharides, because of the gram-negative bacteria, this changes the microenvironment completely within the root canal system. Now, because of this change of the environment, microenvironment, this changes the process from regeneration to repair. That is why the calcification or barrier, hard tissue barrier sometimes forms inside the canal. And as far as the pulp vitality is concerned, it is not accurate because it is not only pulp that is formed within the canal. Sometimes it can be periodontal ligament cells also. So it is a mixture of everything rather than pulp and the cementum and the dentine alone. Okay, now some studies have shown that with MTA apexification also there can be maturogenesis, that is the root lengthening takes place. A few case reports have been reported. Now the probable reason why they have mentioned is that the MTA might have been come into contact with the blood or the apical papilla stem cells in the periapical region. That could have led to this maturogenesis, even though these are all accidental findings. I'll present you one case where we have managed using revascularization. A patient presented with bilateral dense vaginatus. He came with abscess, bilateral abscess. Excuse me. And he was not willing to go for extraction. The parents wanted to somehow save the tooth. So we decided, we explained the option of revascularization to this patient. So in the first appointment, we did the access opening, triple antibiotic paste was placed. And the second appointment, it was removed and MTA was placed on both 3-5 and 4-5. Now, if you look at tooth 4-5, the apex was wide open in the periapical region. And tooth 3-5, the additional fact was there was a middle root resorption present. Internal root resorption was present in tooth 3-5. Now, during 3 months follow-up, the tooth 4-5, there was no signs of any pain or sinus tract. When tooth 3-5 also demonstrated clinically, there was no problem. But radiographically, the internal resorption area continued to increase for tooth 3-5, while 4-5 was clinically normal. During 6 months follow-up, the patient came again for a follow-up procedure. So it was noted that tooth 4-5, the root elongation continued. But the 3-5, the striking feature was that the internal resorption widened more and there was some kind of a bone resorption in and around the tooth. So we understood that there was something wrong with tooth 3-5. So we removed the MTA that was present inside the tooth 3-5 and we did a revascularization. Whole procedure was repeated again. And this time we pushed MTA little more into the area of the internal resorption. So during the 9-month follow-up study, follow-up radiograph, it showed that tooth 4-5 was perfectly normal, almost root closure was achieved. Even tooth 3-5, the root elongation continued, the resorption area was reduced completely, and also there was some amount of bone deposition in and around the tooth. And this was the 1-year follow-up for the tooth. Both the root apex was completely closed and there was good amount of bone healing with around the root 3-5. This is a comparison of pre-op and post-op, 1-year post-op. If you see for the tooth 4-5, you see the ideal criteria here. It was something like a stage 4 type of healing where there was complete obliteration of the root canal space taken place. The root canal space was completely obliterated. This was another case where the patient presented with a traumatic injury. They presented with a draining sinus tract. Again, revascularization was attempted. This was the 1-year follow-up. Here, the healing was less ideal. You see the stage 5, a stage 5 kind of development was present initially, and later on, the root apex was closed, but it was blunt. The stage 5 turned to stage 2 here. Here, initially, if you see, there is some amount of dentin deposition, bone deposition in between, and later on, the root apex turned to be blunt. But still, the apex was closed, and the root length was achieved like the adjacent tooth. So the crown root ratio was accurate for both the teeth. Now, if we compare all the procedures that I have mentioned, apexification with calcium hydroxide, apexification with MTA, or revascularization, definitely the advantage of revascularization is that it promotes root lengthening and also root widening takes place compared to the other two techniques. Now, will the outcome vary whether it is a traumatic injury, whether it is a carious exposure, or any other reason? Now, studies show that irrespective of the etiology of pulp necrosis, it does not affect the regenerative endodontic outcome. So, whether there is a carious exposure or a traumatic injury, the regenerative endodontic procedure is a successful one. Now, they have tried using autotransplantation pulp from the deciduous tooth. Then they have tried using buccal pad of fat as a scaffold. Then even they even have attempted a single visit root canal, single visit endodontic procedure also. Now, all these studies have been a one-off study, and there is limited evidence. Why? Because these case reports, when they report only successful ones. So we require much more evidence to be done routinely in clinical practice. So that is why we always tend to go for the conventional two-step endodontic procedure, regenerative endodontic procedure, rather than going with one step or using the other scaffolds because of the limited evidence. So to conclude, whenever we get any stage of open apex, we see at what stage it is, non-vital young permanent teeth. So this classification was given by SPECT. If it is a wide open apex, whether it comes in stage 1, 2, or stage 3. Generally, they say if the apical foraminal opening is more than 1.5 mm, it is best to go for regenerative endodontic procedure. If it is less than 1.5, you can go for apexification. Or even less than 1.5, if the crown root ratio is less ideal, you want some more of the crown root ratio to increase, you want more root lengthening, then you can attempt revascularization in such procedures. Once the apex is closed, definitely we go for root canal treatment. So that concludes my presentation, and I would suggest you to go through these few articles where they have comprehensively explained all these procedures with evidence. Thank you so much, everyone, for your patient listening, and I'll take any questions if you have any doubts.
Thank you, sir, for the amazing session. Now you guys can post your questions in the query box. So we have a question here. Is it necessary to do RCT followed by revascularization?
Okay. Now, generally, we don't do any RCT following revascularization. We continue to follow up the teeth as long as there is no sign of any periapical changes or any clinical sign of any abscess or any draining sinus. There is no need for any RCT. Now, one small problem that we generally face following revascularization, first, the canal calcification takes place. Second thing, there will be presence of MTA in the cervical region around 3 to 4 mm. To go through that barrier, it is quite difficult. So these are the two hurdles when we go for the root canal treatment. So generally, we don't do any root canal treatment because we assume that the root canal space is completely filled with pulp or pulp dentin complex.
Thank you, sir. So the next question is from Dr. Sharon. So the question is, Doctor, initial treatment given by BDS doctor before endo appointment?
Sorry, I didn't get the question.
Treatment?
Yeah.
Sir, should the initial treatment be given by a BDS doctor before the endo appointment?
Okay. It depends. If you are confident to handle the case, if you know that you have made the right diagnosis, if you know that you're planning for this treatment option, then there is nothing wrong in attempting the treatment. You can proceed, you can complete the treatment, in fact. Only thing you must know what procedure you're going to do.
Got it, sir. So the next question is from Dr. Ninu. How do you remove MTA when you attempt revascularization?
Okay. We're removing MTA, we used ultrasonics to remove the MTA that was present.
Yes, sir. Thank you, sir. So the next question. Okay, sir. The next question is, sir, so does the tooth become vital after revascularization?
Okay. As I mentioned, some cases the tooth responds positively to pulp testing, but not always. Why? Because as I mentioned, this is more kind of a repair rather than regeneration. So it is not pulp cells per se that forms inside the canal complex. It can be a mixture of pulp, it can be periodontal ligament cells, sometimes it can be bone, sometimes it can be cementum. So it can be a mixture of everything. Usually, sometimes they respond to pulp vitality, sometimes they don't respond to pulp vitality. But we always go for clinical as well as radiographically to check whether the treatment outcome is successful or not.
So the next question is from Dr. Lakshmi. BMT up to what size file is recommended for anterior teeth, sir, if this tooth is in stage 4?
Okay. Now, generally, if you are going for apexification for an anterior teeth, instrumentation, it depends upon how much amount of dentinal thickness is present. Now, if dentinal thickness is quite good, sufficient dentinal thickness is present, then you can enlarge up to 50 or maybe 60, maximum 60, not beyond that. It is not required. Enlargement is not required. Maybe enlargement is required only for placement of the GP. Beyond that, it is not required.
Thank you, sir. So the last question for the night. Is it necessary to keep a moist cotton and leave it for 1 day over the MTA before the final restoration?
It is not required to place a moist cotton pellet, because when we place moist cotton pellet over that, we place temporary. Again, we have to remove the temporary. So it is not recommended. Directly, we can place MTA, over that we place GIC. Now, MTA, as we know, sets in presence of moisture. There will be minimal or some amount of moisture that is present, even though we use paper points. Some amount of moisture will be present that enables the MTA to set. So again, specifically placing cotton pellet is not required.
Thank you, sir. So once again, thank you, sir, for being with Online Dentistry. And here we come to the end of the session. So stay tuned to the next 4th Wednesday for another punching session from Online Dentistry. Thank you, sir. Thank you all. Good night. Stay care.
Thank you so much, everyone, for your patient listening. Have a good day.